This is Erica Mello, and welcome to podcast number 24. This is about a patient of mine who had arthroscopic surgery to repair a torn labrum in her left hip. And she had lingering symptoms post-operatively, more specifically thigh tightness, groin pain, primarily when she walked and when she went up the stairs. So her surgery was successful, but she was not able to walk long distances without that gripping sensation in her thigh. And she was not local to me, so she flew in to see me 3 or 4 times. And I think that this also shows the power of trying to treat somebody virtually or consult on somebody virtually via email or just having her come in 3 to 4 times over the span of a year. And she ultimately got better. And the interesting thing with her is it really wasn't her hip that was the cause of these issues. It was a lack of control, as you'll see as you listen. Her foot, her pelvis, both externally and internally. Hope you enjoy it, and Susan and I really would love if you could leave us a review on iTunes if you enjoy the podcast. Thanks a million, and have a wonderful July 4th and a happy holiday. Hey everybody, this is Erica Mello and Susan Clinton, and we are Tough to Treat. Hey Susan, how are you?
I'm good, Erica. How about yourself?
Good. We are recording this at the end, for June. Today's June, and
It is
muggy and humid and disgusting in New York, but hopefully we will have better weather. Let's just get right to it because this is a really interesting patient of mine and controversial for people who have labral tears in their hip. So in short, a patient of mine, she actually lives in another state, and she flew in to see me because I treat her brother-in-law, and so she sometimes has business here in New York and such, and she had chronic or persistent, I think is the buzzword now, left hip pain. Primarily anterior, medial, in the groin, going down into the adductor. And she's had it for quite some time. She ended up having an MRI, and it revealed obviously a torn labrum, okay? And she did some rehab in her home state, and she just really wasn't getting any better. And she ended up having surgery, arthroscopic surgery to repair the labrum. And I spoke with her via phone about 3 to 4 months later, and she was still on crutches, which is not normal to be on crutches.
Yeah.
Right? So, and I think there may have been just a little bit of stress-related things with regards to that as well, but she just couldn't get off the crutches, and she ended up making an appointment to see me. By the time she came in, which is probably about a month later, she was off the crutches. So I sort of chatted with her on the phone a few times and had her work with the therapist in her state. And what they were doing initially, they were starting to just really strengthen the hip and work on the hip and the glutes. And I think that really flared her up. Even, with the crutches, she was doing like bridges and clamshells. And even though it's non-weight bearing, that kind of exacabricated things, right?
The lovely clamshells.
I know. I like that exercise, but it's not for everybody.
That's right.
Certainly not post-op hip 3 to 4 months on crutches still. I don't know. That's just my personal opinion. So basically, to make a long story short, she comes in, no crutches, walking. Her chief complaint still post-operatively was the pain had gotten better. She was getting this tightness and this sort of a little bit of groin pain, but it was more lateral. So anterior tightness, rectus tightness, a little bit of lateral hip pain, not near the bursa, but sort of that outer groin area when she was walking. That was her chief complaint. The minute she stepped forward with the left leg, the whole thigh would tighten up. She also had issues with stairs, obviously, but that was not a priority as she just needed to start to walk first. And I don't know what you think about this active straight leg raise test, but she also had, because she was doing these active straight leg raises in her prior rehab, she said, I also can't lift my leg up. And I'm like, just show me. And so she said, and she showed me this active straight leg raise. And I know in the literature, they talked about, having, the active straight leg raise being sort of specific or sensitive for pelvic pain, but I don't necessarily think that's the case. I don't know what you think about that.
Well, I think that the active straight leg raise test was first initiated by, I believe, the researcher is Gutke, and they were looking at clients in pregnancy and postpartum.
Yes.
And they were looking to see if they were using that test to see if perhaps it increased pain, and if it did putting a belt on around their pelvis help the pain?
Yeah.
That was the original research. It's been kind of like pulled along this string and pulled along that string now, and some people say that it's just a great way to see if deep postural control muscles are all coming on. But the whole idea behind it was with that population.
Yeah.
Now I think it does have some good things that it tells. I've used it on people without pain just to see how their coordination system is working, rather than just specifically only with people with pelvic girdle pain during pregnancy or postpartum.
Yep. No, I agree with you. And I think because that bothered her, I'm like, okay, I obviously need to look at that. So I just had her just did a quick standing assessment. I like to just look at standing because all these movements, walking and going upstairs start from standing. Didn't see anything really crazy in standing. She probably had a little bit more weight on her right leg. Not surprising after all the issues that she had. So what I did was I actually took a look at her step forward. So I had her just do, instead of just walking down the hallway, I said, step forward with your right foot, then step back, step forward with the right to see the strategy. Then I had her do her left foot, step forward with the left and step back. And what I noticed immediately when she stepped forward, first of all, she stepped forward and got her weight onto the left leg. It reproduced all of her symptoms. And what I noticed was her entire pelvic girdle was rotating to the right. That's supposed to happen when you step forward and with your left leg. It's supposed to happen. She was going way right. I'm in here doing my hands again. Her shoulder girdle was turning way to the right. And I'm like, well, obviously she's not walking right. Something's untwisting in her nervous system so she could walk straight ahead. So I said, okay, let's just do an arm swing, because she wasn't really moving her arms. I wanted to see what it looked like when she actually had a little bit of momentum in her gait. So I said, step forward with your left foot and just see what arm she uses. And she took her right arm across her body, and that felt a bit better. She still had a sense of stiffness, but when she actually started to use the arms a bit, it felt better.
Before you go forward, did she, when they did her labral, whatever they do these days, or then, did they also do a hip flexor release?
No.
Okay.
No, but they did what did they do? God, it was a while ago now. They did a lateral release of something, and I do not remember actually what it was, to be honest. They did not do the hip flexor release, but they did a straight scope, and they did release something, but I don't remember. It was a couple of years ago now, so I'd have to go back and look.
Okay.
It was way more than, that's a good question. That was way more than your straight scope. And she was, hypermobile, the same sort of presentation. So when I had her move her arms, she felt better, but she still was not really, she's still shifting her weight over. So I had her walk down the hallway just to see, because the rooms here are just not enough. I need to see the hallway. I had her walk down the hallway, and she looked okay because she was using the arms. Then I had her take really big steps. I don't know what you do, but I tend to have people take very big steps when they walk, because if there's anything that's going to be glaring, or I'll see it there. And she took a big step with the left foot. She was completely off balance, and she was like almost falling to the right. Then I had her do a mini lunge just to see how that looked. Not much of an issue there. So I said, let's walk backwards. And she's like, and she started to walk backwards, and she's like, I have no pain. I'm like, yeah, you have no pain because you're walking backwards. And she's, how come I have no pain? And I'm sitting here thinking, how am I going to explain this to her, from in a consumer perspective? I said, well, I started with the whole threatening, that your nervous system, it's not a threat to your nervous system, and blah, blah, blah. And I said, well, number one, you're activating certain different muscle groups. obviously when you walk backwards. Your main issue is when you swing the leg forward and you place weight on it. Walking backwards is a completely different movement pattern. And
Mm-hmm.
and a lot of people who have issues walking forward can walk backwards. And I actually like to give them that because it makes them feel better. So I don't know
Mm-hmm.
if you would have answered that differently, but she was really harping on that. She's like, now we'll just walk backwards. I'm like, no. You could do that as an exercise, which I actually ended up giving her to fire the glutes a bit more. But what I ended up in the end, I think, saying is there's obviously some muscle imbalances here that just need to get rectified.
Yeah, usually when I run into that, and one of the things I do with gait is I do change it. I have them take longer steps. I have them take shorter steps.
Yep.
I have them bring their base of support closer together. I have them bring it farther apart, in an effort to kind of like, what's happening here? At first glance, it would almost sound like weight acceptance was a problem for her because every time she swung her leg out and put weight on it, it hurt, right? But then when you walk backwards, it's fine. So it's not weight acceptance. It's not a joint issue. It's so that immediately starts to say to me, this is some sort of muscle coordination issue.
Correct.
And it makes a lot of sense. If you've got somebody who was just on the edge of the scale of being, Gumby rather than the fire hydrant on the other end, their motor plans and stuff are different.
Yep.
And, she went from having, maybe a different response in her muscles around a joint that was giving her, danger signals to having surgery on it and her brain not really kind of, just still trying to figure out what do we do with this? How do we figure this out? And I think it's great to switch the patterns up because if nothing else, you showed her right then and there that she could step on the leg and it doesn't have to hurt.
Exactly.
She doesn't have to have a pain response. But I agree with you. In the moment, I kind of use your muscles are working differently.
Yep.
So now we know that you can actually put weight on that leg. It's maybe a coordination of movement and control. Right. It seems to be the biggest issue here. So that's nice because you got the buy-in right away with her. That this can change. Like immediately it can change.
Yes. So and I actually ended up having her walk backwards as a little exercise while she was here, just to get her brain used to bearing weight without pain. Mm-hmm. And that really changes that whole, change your brain, right? So then I said, okay, so I got her back in the room and it was pretty obvious where the muscle tone was. Her lateral quad or TFL, all the front muscle, adductor, all quite tight. And there was something really pulling her in. And I was thinking in the back of my brain, maybe it's something internally in the pelvis, just in the back of my brain. Mm-hmm. I thought that. And I just sort of kept it to myself because I'm not a pelvic floor therapist. But you'll see what I ended up doing or how this all turned out. So the way I modify the pelvis, and this is a lot of what I learned up with Diane and LJ, I ended up neutral. I basically put my hands on her and I facilitated a better movement pattern, for lack of a better word. Put my hands on the pelvis. I said, this is what you're going to do. I'm going to limit, you need to rotate to the right. Let me just do some modifications to your pelvis just to sort of help you get a better movement pattern with walking, and then we'll see. Mm-hmm. I actually did that in the hallway because I needed her to take a few steps. So I got her back out of the room and I neutralized it. I took out a little bit of that excess rotation and just had her walk with a little bit of, just sort of aligning it, but, for lack of a better word. And she felt better, but she still was grabbing. So I then applied different compressions, also like how a belt would be, mm-hmm. like Diane's compressor belt, posterior compression, anterior compression. So I gave her little bits of compression. So at the end, I ended up helping her with the, sort of aligning the pelvis, sort of neutralizing it, giving her some posterior compression, just putting my hands on the tops of the iliums down a little bit and just sort of compressing the back of her pelvis, almost like mimicking some, balancing the forces in the pelvis, mimicking some posterior chain activation with my hands.
So basically using your hands to increase proprioception.
Right.
And getting the muscles that have been up to this point inhibited to fire, because it sounds like she was, had that classic kind of muscles that were overfiring, especially in the front, and muscles that were underfiring in the posterior chain. That's a great way to just kind of get on there and get on the pelvis a little bit and just give them a little compression appropriate, and that basically fires that proprioceptive system up, I think.
Yep. Because she had been doing a lot of glute work, obviously, and mm-hmm. it wasn't really helping. And I was like, well, if you're doing it within a more,
Yeah.
exactly. So anyway, so I sort of walked with her, I was behind her with my hands on her pelvis, and she's like, "Oh, that feels a lot better." And she's like, "How come?" And I basically gave her the whole explanation. It's just balancing the muscles, balancing the forces
Mhm.
within your pelvis. It's waking up certain muscles that are really, aren't at
Mhm.
the party, so to speak. And she got that. And I applied other compressions, like anterior compression, which made her worse, obviously, but I got the buy-in there. So I did the anterior compression, which mimicked all the forces in the front of her pelvis, which were already overworked and sore anyway, and that
Mhm.
made her worse. So she was like, "Oh." So, and she had been doing a lot of abdominal work as well. And I was like, "That's
Mhm.
probably not the best thing for you at this point if you're doing straight leg raises or things that are working your lower abdominals right now, because you're a little bit overworked in that
Mhm.
anterior chain. What you need for walking is more posterior chain, more glute work, more activation." So what I ended up doing, she came to me for 2 days in a row. And when I had her, so when she was stepping forward, her whole left lower quarter was internally rotating. Her foot was internally rotating. It was pronate. It was just abnormal internal rotation. So I got her on the table, evaluated her active straight leg raise. Same thing, tightness. So because the compression really helped her in weight bearing and walking, I ended up applying the same forces on the pelvis. I just neutralized it, put my hands behind her pelvis, gave her some posterior compression, and her left leg flew up. She's like, "Oh my God, this is so much better." So right then and there, the same pattern compression, the pattern of compression helped with the active straight leg raise, an open chain, but still it really helped for her.
Mhm.
So I, because of the time, because I knew she was coming back the next day, I had the Diane Leak, the compressor belt here, so I ended up giving her that overnight. I had her put it on. There's a couple straps where you basically you adjust it for posterior compression. I said, "This is what you're going to do. Keep the belt on." And I explained to her how I wanted it to be put on. And she walked around here and she felt a lot better. And then I actually gave her some backwards walking to do in the hotel room, things like that, because I knew she was coming back the next day. She came
Mhm.
back in the next day, and she said she felt a lot better with the belt. So she ended up ordering the belt, and I ended up doing some taping with Leukotape and Hypofix.
Mhm.
That same thing as the belt, basically, just posterior compression, start
Mhm.
midline, and then just go back with one piece of Hypofix on one side, one on the other, and just reinforce it with the Leukotape. So that's what I did with her, like the first day. I gave her, ultimately, she needed some release of some of the muscles in the front, but in my experience, I don't know about you, but the rectus femoris turns on. You could sit there and massage and stretch. It's just not going to turn off with these patients until
Right.
you train a new motor pattern. Don't you agree?
I do, because it's not a tightness issue. It's
Right,
an over recruitment issue.
right,
And the best way to stop a muscle from over recruiting is to get the its antagonist to begin recruiting.
right,
Change how they're moving so that it's not being called upon. That
right,
other muscles have to wake up. It's kind of what I like to tell when I teach to therapists is, when you start changing patterns, like getting people to walk backwards, you're basically kicking basal ganglia out of the chair and making it go find another motor plan to give to the motor system. And there's a pause, and it's a little slow, and the brain, the reactive brain, has to kind of respond to that command rather than to everything goes on the pain loop.
right.
And so then you begin to start changing muscle activation and stuff. It doesn't sound like she had a force production problem. It sounded like an inhibition over recruiting type of pattern that you
Yes,
see. And I agree. People foam roller and do all kinds of crazy stuff and aggressively stretch their rectus femoris, and to what end? It's become the bully on the playground, as Julie Weed would say.
right. Yeah,
And you got to invite the other people onto the playground, maybe not just try kicking the bully off.
right. Yeah,
Yeah.
no, I agree. And she may have been, weak in her transverse abdominis. I just couldn't even get in there to feel because her obliques were always firing like crazy, and she was kicking in all of the, her rectus. And I don't think that, she was saying that, they were doing a lot of abdominal work. And I said, well, at this point, I probably wouldn't give that to you just because you're going to you're going to overactivate the wrong muscles. And we just need to balance some forces first before you start, going back to doing that. So she came in, as I said, the next day she felt a lot better. And it's because she was leaving, and I normally wouldn't have gone to this so quickly. I looked at her foot because I had her, I had her do the step forward again. I had her do her active straight leg raise again with the tape on, and she was probably 70% better with all of that, not having done
Mm-hmm.
anything else, okay? And I ended up, to make a long story short here, I ended up just taking a look at the foot and her history, prior ankle sprain, the whole thing. She had no control of her left foot. So who knows? Did it start at the foot and gave her the
Mm-hmm.
hip? I said, imagine having had arthroscopic surgery to repair your labrum and to find out that the hip is still the source of the problem, which it was not in her case. So she was
Mm-hmm.
almost relieved. I was like, your hip's fine. It's just you have a strategy that you're still using that you could have caused this labral tear in the first place, or you could have had structural issues in your hip. So who knows? It doesn't matter at this point. So with the pelvis, the foot was better, but it still was not not really optimal. So I ended up, if people listen to the podcast, people know I do tape a lot, but I did not tape this foot. I was like, there's enough input to her nervous system at this point. She doesn't need to have tape everywhere. And I wouldn't have done it so quickly anyway if she had lived here in New York. So
Oh,
I
sure.
basically
Yeah, you were
sent
trying to do
her,
some things for her to get home with.
right. So I gave her some basic walking backwards, okay, and she wanted to know if she could see a massage therapist, and I was trying to find her a good physio in her state in the interim, and I said yes, they can do your psoas, do all of that, it'll give you short-term relief for sure, but it's not going to really, you're going to go back to your old strategy. And she was like, okay, fine. So she ended up getting the belt at home, and I had her do some basic backwards walking, and then I just gave her an easy bent leg raise to do, not a straight leg raise, just an easy bent leg raise with the belt or the tape on, just to give her a shorter lever to do that exercise with, maybe to
Mm-hmm.
recruit a little bit lower abdominals. And she was fine with that. So because I believe that her foot was secondary, I ended up giving her some foot control exercises.
Mm-hmm.
And I'm not a big fan, I don't know if you are, of like doing these towel crunches, things like that. That they always overdo those types of exercises. So I didn't do any of that. I basically gave her seated heel raises, actually, to make sure she's using the gastroc. I had her, when she was doing her backwards walking, to look down at her foot to make sure she was actually doing, toe heel with the backwards walking.
Mm-hmm.
And I ended up just having her do, not initially, but I said this would be like a third phase or whatever, or second phase of doing like just maybe wall squats against the wall with like little heel raises, things like that for the foot
Mm-hmm.
control. I said, just make sure you're not going up and you're inverting or twisting your foot, because that's a loss of control, and that you're not a dancer. You just make sure you're doing your heel raises and that you're in somewhat of a neutral position. I showed her the position I did not want her to go in. So with the foot, I gave her seated heel raises, backwards walking toe heel, squats with heel raises against the wall to start, just for the foot control.
Mm-hmm.
And I'll stop and you let me know what your thoughts are at this point, because I'm not finished
yet. Yeah, no, I think that's great. I love the idea of, the fact that she was going to see you 2 days in a row, and you just needed to do some things to get her system to wake up and understand that changing the strategy was going to be the key. Because, and again, I think when we think about taping, we need to think about what it actually does. And it's a sensory input, and I think it's a proprioceptive response, which, as we all know, with the motor control system, is what really is part of the whole coordinated system. Without proprioception, it's hard to tell where we are in space, and our muscles aren't really able to grade and scale as well. So that's where you get, sometimes we develop these patterns of over recruitment and some of these strategies, because we're moving in response to an output of pain.
Yep.
And our brain is telling those muscles to do something completely different than what, maybe they would have done in the past. And who knows if the foot set that whole thing up or not. The idea is the strategy's there. Let's work on the strategy. And because changing strategies with her helped. You found that out immediately. In addition to the foot exercises that you did, one of my favorite things to do is to get them to stand and put their fingertips on the wall And, we're talking about just changing strategies and weight bearing and things like that. You can pull the whole lower quarter in this way, is I'll just have them stand with their fingertips on the wall, because that prevents the rotation through the trunk. And they have to increase the control in the pelvis to do this, and begin to just come up off the heel and then just lift the foot up off the ground and put it back down. So it's kind of like doing a single leg stance, but it's doing it under a different kind of strategy position. And they have to develop a foot to do that, because they can't just squish down on their foot, because then they're going to lean all the way to the side, so that the fingertips on the wall keeps them honest as far as, I want you to stay in a cylinder and work on this. And it's kind of like doing the knees up when you had our supine. It's like doing that in a standing position. So you have the weight bearing and proprioception into the foot.
Yep.
Helps them with that beginning step off that you were looking at with her walking, which is really kind of cool, because you could actually also do that and go into a step back. And what you were doing was that eccentric control, with that walking backwards. And so people who find that they're not good enough, like her patient was, and you need to break it down a little bit more, you could actually have them step back onto their foot and then step forward again. And, they can do that with the wall to help them. And those are great ways to really get foot control. And you know how I think about foot control. I don't do any of the toe crunches and, or roll crunches and things like that, because of all the dancers that I've treated and performing artists that I've worked with. And those strategies don't really work. They actually make their foot a bit more rigid, as far, because they try to do that. And I already have that problem with a lot of the people that I see, is they're over recruiting their foot. They're either over recruiting their foot completely, or they're completely not recruiting it at all. It's just like flat as a pancake, or or smushed out, or it's like this little rigid kind of claws on the floor. And so I love those strategies like that, where it's movement. They're going up, they're going down, they're moving forward, they're swaying forward at the ankle with the body straight. Is amazing for foot control. And because it develops the entire plantar surface, as well as the soleus and gastroc, and you have to use posterior chain to control the sway. Those strategies, I'm buying right into them, because I love them, because I think that it's the whole lower quarter that's involved in the strategy, not just the foot.
No, I love it. It's great. I agree. And sometimes people have difficulty with giving foot exercises, but you can incorporate them in. I ended up having her do forward and backward lunges just like that. I said, this is what, and that was the next phase. And that's great, because they need to be able to accept the weight, and backwards and forwards, and even doing little split squats with heel raises, and then if she were coming more regular, or had been coming more regularly, I would have probably progressed her, no surprise here, with a little bit of rotation, lateral movements with the foot, things like that. Even though for her, side to side was not really a problem with the hip or the foot. I feel that you need to train that, because that's part of life, and rotation is part of life, and I would have introduced that at some point. So the foot control was very important for her. So she ended up doing a lot of that. I progressed her via email, and she had been through, I don't know how many physios in her state. We ended up finding somebody at a university there for her, and she was seeing a massage therapist as well. So she ended up coming back to see me probably a few months later, and I reassessed her. Her step forward was a lot better, still getting a little bit of tightness, but the walking was better. There were some cognitive and emotional issues with her as well, which we had to nip in the bud. We just had to, because of the persistent nature of this. And she was very hopeful. And so we had to work on stairs now, and a lot is very different with stairs from walking. And so I just had her go up and down the stairs here a little bit. And it was just ultimately the same issue. We just needed to increase the load in her exercise program. And then I had to do the straight leg raise, and that was significantly better. But she was still feeling it in the front. So I went and I pulled out my listening from the Baral. I put my local listening and my general listening right on the groin, and I felt a really big pull like way in. And I'm like, this has reinforced my thought of maybe some hypertonic pelvic floor muscles, not my zone of practice. So, I can, get a pretty good idea of some of the external pelvic floor muscles, if they're hypertonic, things like that. And she really wasn't. And I just said, because I really ruled out the hip as the driver, the knee. It was primarily the pelvis externally, the forces, and then the foot. And she was really improving. So as we started to increase the load, I had her start to do more squats, more lunges. I had her start to do a little bit of rotation, lunges with rotation. Something in the back of my mind said, you need to see a women's health therapist, a pelvic floor therapist that does internal exam, because I think there's something inside your pelvis that's just causing this issue, that's causing this residual, this last 30 to 40% that I can't get at. And lo and behold, she did. She found somebody in her state, and there's significant hypertonicity in the pelvic floor. And after 4 sessions, she was almost good to go. She came back. So I don't know I corresponded with the therapist. I don't know exactly what the treatment was there, but then she came back for a 3rd time, and I ended up reassessing everything. She was 90% better, and she wasn't really using the belt anymore. She was taping occasionally. I had taught her how to taping occasionally. Her foot control was much better, but she still every so often had this sort of tightness in her thigh. And so I progressed her exercise program to do a little bit of stepping up the stairs with more proprioceptive cues for her glutes, things like that. I really just started to load her system more. She did not belong to a gym. She is in the house, in the suburbs and in the Midwest. So it was not something that, she wasn't a gym rat. So it wasn't like she needed to go in and do squats with 100 pounds on her shoulders. So I just literally, what I told her at the time is I said, we need volume here. We just need volume. You just need to get your endurance up in your muscular system, in the hip, pelvis, as well as the foot. So instead of doing like 3 sets of 15, you need to do like 40 to 50 reps. I just need volume to load your system and to see where your buckle point is at that point. So she complied. And I kept in touch with her via email, and she came back in one more time to say hi and reassess, and she was much better. She was good to go, basically. But I thought that was very interesting with the pelvic floor, because, I'm going to ask your opinion. Because I resort to this local listing sometimes, because sometimes it's a gut feel for me, especially with somebody like her, because the pelvis was the primary issue. I didn't need to go in internally initially at all to figure that out. And then her foot, that got her 80%, maybe 75%. But I think there was something inside that was pulling, and I can't explain why. So anyway, so it was whatever those muscles were released, retrained out in her state. She came back, I loaded her system more, and she was significantly better. So
yeah,
I would like your
great
thoughts on that.
Yeah, I'd love to give my thoughts on that, because the first thing that I thought of when you were talking about stepping out and stepping forward and the muscles that were over recruiting, is my thought was, and I bet her obturator internus is over recruiting as well. Yep. And here's the reason why. When you have a pelvis that you can put compression on and you can get some proprioceptive input into, and they begin to feel better, or they begin to change immediately, you're also dealing with the obturator internus, because it's the biggest, broadest, flattest muscle that goes along the entire lateral wall of the pelvis. It reaches from the pubic bone and it crosses all the way back. And it's huge. It's a gigantic muscle, and it is primarily a muscle that comes in and holds the pelvis. From the inside, you got the glutes on the outside, you got that obturator internus on the inside. It's an external rotator. And so if it's overfiring, then you've got that whole kind of thing going on, and they can't really access and move in the same way. And so oftentimes it learns to, in the face of pain, wherever the pain is coming from, or whatever the pain pattern the brain is giving, in that kind of a pattern, that's usually an overfiring obturator internus. That's the issue. And that's probably what they found. Yeah. I think it probably would have, even without going internal, might have corrected itself over time. Yeah. So sometimes you can go in and just identify the muscle and see if certain movements begin to get that muscle to not over recruit, which is the way I work anyway. I don't like digging around on stuff, but I do like feeling, okay, if we put your leg in this position, how does that change the pattern? Can you move this way? Does that change the pattern? Can you move that? Oh, no, that makes it, I feel it really coming in hard here. What about here? So they can begin to identify and understand, oh, when I do this, it feels kind of like what you did with backward walking. When I do this, it feels better. Of course it does. Because it's a change of strategy. So that's fantastic, and probably helped her just get that extra little piece of coordination into that, and again, like that whole thing is get the strategies going, the pain response lowered, and load, so that they get that piece. I probably would have just done one other thing, and you may have done this, but oftentimes when I'm thinking obturator internist, I get them prone, because it's much more of a rotator when the hip is straight rather than flexed.
Yeah.
Just because of the position that it's in. So I'll get them prone and then bend their knee. And I'll look at knee movement. I'll look at their foot movement. So we're going internal and external rotation of the hip.
Right. Yep.
And so I'll look at that whole pattern there to see if, and generally what I end up finding is as they begin to move into internal and external rotation, their whole back and pelvis is moving.
Yeah.
And the legs should be able to move without the back and pelvis moving.
Yes.
And so that to me tells me that there's probably some sort of a coordination recruitment problem.
Yep.
And the obturator internist is being pulled in with that particular strategy. So that tends to be a good way to get in for those who aren't going to go internal to feel muscles. And then, of course, all the things that you were doing were the right things, especially with the lunging and stuff like that. Squatting is fantastic, as we all know. And even just sit to stand, changing strategies with sit to stand can change strategies of the pelvic floor muscles. So if the levator ani on that side was involved, and being able to do things like moving from anterior to posterior and really having control, anterior posterior movement of the pelvis, having control there with the emphasis on kind of being able to move into that anterior and hip flexion, which is probably a strategy she was avoiding because it pinched in the front. Yeah. And so she probably learned to not do that and maybe even circumvent around that, which may have been some of that extra rotation, on that right side to do that. And so that muscle really, so that pelvic floor muscle on the side never really gets to move into its lengthening or elongation because it's staying shortened on one side while the other side is lengthening to come up if she's shifting weight to get out of a chair and out of the car and, those kinds of activities. So, that part fits in very well with what you were doing. Yeah. So.
And I think with the belt and the taping, it was in essence it was sort of opening up the front of the pelvis if you want to take a look at it that way. So that clues you into like, okay, she likes posterior compression, but that's also anterior decompression, if you want to look at it that way. So for her, she was opened up more and felt better that way. And I do agree with you. I think that since she was not local to me, I didn't have the luxury of seeing her a lot.
Absolutely. Yeah.
So I had her probably 4 visits, maybe 5 at most over the span of a year. And I was really, I couldn't find a physical therapist in her state that looked at the body the way we look at it. So she ended up finding somebody in the university, as I said, and and she actually FaceTimed me during the treatment session. I felt mortified, but I had to do it, and we were just trying to discuss between the three of us actually, what the treatment plan would entail. And actually, I think that really,
I think that's brilliant. I wish we would all do more of that. Because at that point, you weren't really treating, you were assessing and kind of consulting. And I think that we all need to be a lot better at referring. I love the fact that you said, I just wanted her to see somebody that, just to confirm my suspicions. Maybe I'm not getting to everything I need to get to. Yeah, you probably could have brought her all the way yourself, but why? When she could find somebody and, thank goodness she found somebody who could, in a few visits, really kind of help just push her up the road just a little further. The name of the game didn't change, just kind of like, let's just, add this piece in and now add this piece in and add this piece in. Like you said, I need to see where you're buckling. I need to see what it is, now that you're moving and doing these things, I need more. So we can see where do you want to be? What do you want to be able to do? And if so, then we need more volume to get you there. I love it.
Right. I think that's ultimately in the end. And I agree with you. I do think FaceTiming, we're not treating, we're assessing and consulting. So, and it was not in my state. So it was fine. I did that a couple times actually, because
Mm-hmm.
the patient's important. And there were a couple times where she was seeing somebody else over in her state that was making her worse again. And I was like, you cannot under any circumstances do these exercises. I gave her the program. So ultimately it's for the benefit of the patient
Mm-hmm.
that you need to bring somebody in. Let's not let pride and our egos get in the way here, because patients at the center of this whole of our profession, to be honest.
Yep.
And I think that, don't take it personally if someone else wants you to consult. I mean, it's not a big deal. It's you learn that way. So
Mm-hmm.
ultimately that's what I did. She's doing pretty well now. I really enjoyed working with her, and it was a lot of email, to be honest. It was good, and just great progressions, and ultimately she just, to this day, she still does some of the exercises I gave her, probably not as many as she used to, but she was very desperate. I mean, this was the emotional issue. I think being on crutches for 4 months, that's a major issue. And I think for her, just to realize that there was hope, and she did get better, and even coming in for the small amount of time she did, it really just it calmed her
Mm-hmm.
whole system down. So
Yep.
she's doing great today. And I just think with the exercise program, at the end, it was just, it's volume, people. When you need to get people up to I mean, she's not an athlete, but she needed to go up the stairs. Stairs is quite a load on the hip, and she needed to
Mm-hmm.
do that, and she needed to walk her dog, and you need volume, 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 volume. And those are my parting words for her. So there you go.
Awesome.
That's it for me.
Yes. Thanks for sharing the
Sounds good.
story.
Oh, my pleasure. Thank
Yes.
you, everybody, for listening.
Yes. Thank you,
And
everyone. And if you continue to like what we're doing, sign up for our newsletter. You'll get announcements about what's going on with Tough to Treat there and our mentoring program, as well as just thoughts about the upcoming podcast that we have going on as well. So, and we'd love it if you would leave us any reviews on iTunes. It means the world to us, and also very helpful for us in guiding us. We love the comments on Facebook and Twitter and everywhere else. Thank you very much for those of you who are doing that. It does help us guide our content, and it does help us continue on. We have such a great time doing this. It's great that you all are enjoying it as well.
yep. Enjoy, guys.
Okay.
Thanks.
Thank you, everyone.
Bye.
Bye.
Bye.